Hi everyone, my name is Anthony Fisher. My colleague Hannah Thacker and I will be presenting a case to you all on atypical hemolytic uremic syndrome, or atypical aHUS. Atypical aHUS is a rare disease presenting with a triad of hemolytic anemia, thrombocytopenia, and renal failure. This disease has many mimickers and is very rare, making it difficult to recognize. Our case report is on a 33-year-old male who presented with profound elevation in blood pressure and laboratory testing consistent with thrombotic microangiopathy, or TMA, as well as renal failure. The patient was recently admitted for a similar presentation, which was thought to be due to hypertensive emergency. At that time, he was started on hemodialysis and continued this at discharge. During his second admission, the patient's course was again complicated by severe hypertension, along with several episodes of bloody stools. Hypertensive emergency remained on our differential, along with Shiga toxin-associated E. coli given the bloody stools. Hematology was consulted early on in this course. However, initial workup was largely unremarkable, besides a low vitamin B12 level. Given that vitamin B12 can cause a pseudo-TMA, we started high-dose supplementation. However, our concern for atypical aHUS was heightened given his presentation and current workup. The C5 inhibitor therapy was held during this admission due to improvement in both his labs and clinical course after vitamin B12 initiation. However, after discharge, an atypical aHUS genetic panel was positive for a variant associated with the disease. He was started on ravulizumab, a C5 inhibitor therapy, and his labs improved, although he does remain on hemodialysis. The main take-home points are that atypical aHUS needs to remain on our radars for patients presenting with evidence of TMA, especially if they have a classic triad associated with atypical aHUS. It can be difficult to diagnose due to lack of familiarity and the complexity of the clinical picture with red herrings such as bloody stools or severe hypertension like in our case. There is ongoing research about varying presentations of atypical aHUS, which will hopefully allow us to be quicker to recognize and diagnose. Quick time to diagnosis can lead to quicker initiation of C5 inhibitor therapy, which is most effective when started early. Given the significant morbidity and mortality associated with atypical aHUS, there is high incentive to quickly recognize, diagnose, and treat.